KGMCH to honor the chairperson.
Anywhere you go for your CMEs or conferences, I will be there. About sir, he is a professor and head of the Department of Anesthesiology and Critical Care and Pain Medicine in JSS Medical College, Mysore. He has been the eminent anesthesia teacher award he has got in 2021 from Indian Society of Anesthesiologists. He has had an Excellence Award and Neon Excellence Award in Educational Initiatives in 2017. He is awarded Best Teacher 2019 by Mysore Medical College and Research Institute. Again Best Teacher 2020 from JSS Academy of Higher Education and Teacher. He has served as an Army Captain in Indian Army, former professor and head of the department, Mysore Medical College. He has been associate editor for Indian Journal of Anesthesia for 6 years. He has been a member of advisory board, Indian Journal of Anesthesia, KJ 2011 till date. He has been a member. He is the advisor to the scientific committee of ISA Karnataka. He has been a member of the board of studies, Mahatma Gandhi Medical College, Pondicherry. He has had 42 national and international publications. He has presented more than 200 invited guest lectures in many conferences and CMEs. Pleasure to be listening to you, sir. Welcome.
Thank you very much, sir. Everybody, and first of all, I would like to thank Dr. Edward Johnson for this opportunity. This is a fantastic, method of making all of you people, just 1 month old postgraduate students, to have a good orientation of what is anesthesia. I can assure you that you love this subject, anesthesia. Many times, even when I joined anesthesia, I didn't know anything about anesthesia, but now I was telling even yesterday that this is the best thing I did in my life for joining anesthesia. And when I was as a postgraduate student like you, probably almost about nearly 37, 38 years back, we were hardly giving much importance to the airway assessment. And there were hardly any tests for assessing the airway also. And regarding the airway gadgets, we did not have many airway gadgets for managing difficult airway. We hardly had, like a laryngoscope we had, and some bougies, and the face mask. And many of the hospitals did not have even fiber optic bronchoscope. So that is the reason during those days, unanticipated difficult airway was to be very common. And it was said also that the 33% of the deaths that occurred due to anesthesia was because of unnoticed accidental esophageal intubation, patient dying of hypoxia. That is why now after many years, now for the past 30-40 years, a lot of development has taken place in the assessment of the airway, and also many of the gadgets have been introduced in anesthesia for managing the airway. And in 1993, actually the first ASA difficult airway guidelines was also introduced. Now majority of the societies have guidelines for managing airway. And you all know that airway management is one of the important skills the anesthesiologist has to have. Not working. So very important that every anesthesiologist has to develop the skill of managing an airway, because effective management of the airway definitely it makes a lot of difference between life and death, and also ability and disability. Now why I am telling you is because suppose if you are not assessed the airway properly, and you do not anticipate a difficult airway, and you come across an unanticipated difficult airway, patient can have hypoxia, and hypoxia can kill the patient. Or it can, even if the patient survives, the patient can end up with disability. That is why, airway assessment is one of the most important things to identify a difficult airway, a potential difficult airway. So what are these, potential difficult airways? Now it can be a difficult mask ventilation, or it can be a difficult supraglottic airway placement, or it can be difficult laryngoscopy, or difficult intubation, or it can be a difficulty in front of neck axis also. Now, how do we assess the airway? There are different methods of assessing the airway. One of the methods is by history, taking a proper history. Second is clinical assessment. Third is by ultrasonography and radiology, and fourth is by nasoendoscopy. But lot of importance you have to give for history as well as the clinical examination of the airway. So regarding the history, very important, one of the histories you should take is whether the patient chews tobacco. And you all know that jardar chewing is very common nowadays, because it can produce a problem, a complication for the patient, which is called as submucosal fibrosis. The patient may not be able to open his mouth, so that is a problem. So that is why the history of chewing tobacco is very important. Another history, for example, if the patient has had exposed himself to general anesthesia before, you always ask, because if the patient had a difficult airway and the anesthesiologist had experienced a difficult airway in the previous anesthesia, the patient would have been told that you have to inform next time when you want to get exposed to anesthesia, you have to tell the next anesthesiologist. So just take the history whether he has had a difficult airway in his previous anesthesia exposure. The other important thing is, history of significant snoring. This is a very important history you should always get, because if there is history of significant snoring, that may be an indication of patient suffering from obstructive sleep apnea. And if the patient, you think that he has chances of obstructive sleep apnea, you just take this particular questionnaire you go for, which is called as a stop bank questionnaire. So you can ask all these questions, and more than 3 or 4 if the questions are positive, then you know that the patient may have obstructive sleep apnea. Why I am telling about obstructive sleep apnea is, if a patient has obstructive sleep apnea, OSA, so these are the patients are likely to go in for either cannot intubate, cannot ventilate situation. Then you can have all kinds of difficulty in managing these patients' airway. Especially they can have difficulty for mask ventilation, difficulty for laryngoscopy and intubation, and difficulty in even front of neck access, because invariably they will be obese as well. That's why this history of OSA is very, very important. Now coming to the clinical examination. So regarding the clinical examination, the external appearance is very, very important. Many times we even now, every anesthesiologist knows that whenever we are going in the road or even in a party, from a distance we know, oh, this patient has got a difficult airway, let him not come to me as for providing anesthesia. So for external appearance itself, and whenever you have an external appearance, for example, now this patient, from the front it looks like an easy airway. Always look at this from the side profile as well. From the side profile you can see this patient having a small chin and a short neck. A patient with a small chin and a short neck definitely will pose you a very, very difficult airway. So then you make the patient to open his mouth. Once the patient opens the mouth, first thing you always look for is the teeth. So always look for, when you are examining the teeth, is there any defective tooth, or is there any missing tooth, or is there an overbite, or the patient whether she or he has dentures. So again, if the teeth are missing, especially if the teeth are missing of upper incisors, it can be a very difficult airway for you, because when you are doing a laryngoscopy, the blade can get stuck there. That's why you may have to even have a dental prop for the patient, or you may have to use some gauze there. The other important thing is regarding the dentures. So if the patient has got dentures, a full set of teeth, it is better you ask him or her to, come with the dentures, because then when you use your mask ventilation will be easy. If the patient has a removable denture, one or two tooth, then it is better ask him to remove the, the denture and then come. So whatever it may be, so you have a dental chart in your pre-anesthetic evaluation chart. So you'll have to fill the chart, and also you have to, write down, or you have to say that a particular tooth is defective. You can put a circle there, and if a tooth is missing, you can always put an X there. Now coming to the other important thing is the interincisor gap. So what is this interincisor gap? Is between the lower incisors and the upper incisors. So usually this is also called as the measurement of the mouth opening. Normal is about 4 to 5 centimeters, but if the interincisor gap is less than 3 centimeters, it can be a difficult airway, because your laryngoscope blade, the direct laryngoscope blade, it has got a width of 2.5 to 3 centimeters. So unless you have 3 centimeter interincisor gap or mouth opening, you will not be able to introduce your laryngoscope. And even introducing your supraglottic airway devices, it will be very difficult if the mouth opening or interincisor gap is less than 3 centimeters. So whenever you measure, don't measure using the fingers, because it can be, you will not know whether it is the patient's fingers or your fingers, or many times you would have assessed the patient, another anesthetist will be providing anesthesia. It is always, always use scale. You should always carry a rigid scale, at least 6 inches rigid scale, and also a tape along with you. Slides are not moving. Okay. So another important thing is, very commonly used test, which is called as the Mallampatti's test. And for this, you have to ask the patient to open the mouth as much as possible and maximally protrude his tongue. And your eyes should be at the level of the patient's mouth. And you just look at the pharyngeal structures. So this Mallampatti's test was introduced by Sheshki Rao S. Mallampatti. So he is an Indian, and long back settled in USA in Boston. So he did his post-graduation from Vizag Medical College. So it is very important to know about this Mallampatti, because majority of your seniors, they would be writing MP grade 2, MP grade 2 or MP grade 1 like that only. So it has become so popular, Mallampatti's classification. So what is the principle behind Mallampatti's classification is, he said that the size of the tongue in relation to the size of the oral cavity is very important. Because when you are doing a laryngoscopy, the tongue will come in the way of visualizing the larynx. So you'll have to push the tongue to the left when you are doing, already I think some of you might have done the laryngoscopy, And if the tongue size is larger than the oral cavity, there is not much of a space for you to push the tongue. Tongue will come in your way, and you will not be able to do visualize the larynx, and you will not be able to do the intubation. So that is the idea, and based on that, so he classified these things actually into 3 grades, but later Samsoon and Eng modified it, and what we practice now is the modified Mallampatti's classification, wherein if you see all the pharyngeal structures, it is grade 1. If you are not able to see the uvula partially, if you are able to see the uvula, then it is class 2. And if you are not able to see the uvula completely, only the soft palate is visible, it is class 3. And nothing is visible, only the back of the tongue and hard palate are visible, it is class 4. So he correlated this into the laryngoscopic view as well. Like Carmack-Lahane classification, what we use for laryngoscopic view. So Mallampatti class 1, he said that you can see the whole of the glottic structures. Like Mallampatti class 4 can be Carmack-Lahane grade 4. So that is one of the important tests you always you can do when you are doing the pre-anesthetic evaluation. Other important thing is, you also have to examine for the patency of the nostrils. Many times you may plan for nasotracheal intubation. If you are planning for nasotracheal intubation, always look for which nostril is more patent, whether it's a left or right. So one is visual inspection. The second thing is you can use your either the back of the hand or a tongue depressor. You close one of the nostrils and ask the patient to expirate through the other nostril. See how much of moisture is settling on the tongue depressor. Larger the moisture area, that particular nostril is more patent. Definitely you can plan to intubate through that particular nostril. Another important person you should always remember is ZH Khan, Zahid Hussain Khan. So he is from Iran, he is an Iranian anesthesiologist. So he put forward one of the important tests that is called as an upper lip bite test. So what is this upper lip bite test? What does it, what information you can get? It is mainly, the forward movement of the mandible, you can know, or whether there is any overbiting maxilla. See, forward movement of the mandible is very important when you are doing a laryngoscopy. When you do a laryngoscopy, when in the, automatically the mandible will move forward. Along with that, the tongue will move forward. Already I have told you that the tongue is the one which comes in your way of visualizing the larynx. So if there is not proper forward movement of the mandible, again it will be a very difficult laryngoscopy. So what he did was, the test is, whether the patient can bite his lip completely with the lower incisors. This is called as the vermilion border. So whether he can completely cover the vermilion border with his, the lower incisors. And if you can completely cover, it is class 1. If partially is covering, it is class 2. And class 3 is, is not able to even, the lower incisors not able to reach the upper lip. So there is class 3. Any class 3 would be a very difficult airway. Same thing you can also do in edentulous patients also. It is not that, you may ask, many of the students will ask what I do, what I am going to do if there are no, teeth at all. So you can also do the same test in the edentulous patients as well. So another important, measurement you have to take is called as a thyromental distance. It is from the upper border of the thyroid cartilage to the chin or the mentum. So this is called as a thyromental distance, and this thyromental distance is usually about more than 6.5 centimeters. And why this is important? This represents a part of the mandibular space. The mandibular space is, if you draw a line from the chin to the angle of the mandible, and from the angle of the mandible to the upper border of the thyroid cartilage, this area is called as a mandibular space. And why it's important for us to know whether this is adequate or not. So when you are doing a laryngoscopy, as you are pushing the tongue will be pushed into this space. So if this space is enough, you know that there won't be any difficulty as far as visualization of the larynx. So if the thyromental distance is less than 6 centimeters, you know that you have a difficult airway. Another measurement you always take is the sternomental distance from the suprasternal notch to the the mentum or the chin. If the patient's head completely extended, you take this measurement. Normally this measurement is more than 12 centimeters. This gives you indirectly, it will tell you what is the length of the neck. If the length of the neck is short, that is if the distance is less than 12 centimeters, you know that the larynx is more anteriorly placed. When you are doing your direct laryngoscopy, you may not be able to visualize the larynx. So again, sternomental distance is very important, especially this is more important in pregnant women and also in obese patients. So another important measurement, that is why I was telling you that you always carry a 6-inch scale and also a measuring tape. So this is again the circumference of the neck circumference. Again very important, you measure at the upper border of the cricoid cartilage. And if it is more than 40 centimeters, you know that there is a probability of difficult airway. And if it is more than 60 centimeters, definitely there are almost more than 35% of the chances that you will have a difficult airway. And more than 60 centimeters also, the problem is the OSA is very, very common. Obstructive sleep apnea is very common. One more thing you will always check is, extension of the head at Atlanta occipital joint. So how do you do this? So you can ask the patient to partially open his mouth, and you can keep a scale here, keeping the head of the patient at neutral position, and then you ask the patient to completely extend his head. So now, another scale you can keep. So this angle is what is called as, the head extension angle. And normally it should be more than 35 degrees. So a simple test is also there. This is called as a Delicant test. So what you do is, you keep your, the left index finger over the chin of the patient, and right index finger over the occipital protuberance when the patient's head is in the neutral position. Now ask the patient to, completely extend his head. Suppose if your left index finger is above the right index finger is at the occipital protuberance, the left index finger is over the chin. So if the left index finger is higher than the right index finger, then it is a normal airway, you don't have much problem. But if this finger is below this finger, then you have a extremely difficult airway. Now why this head extension is important for us? Normally what is important is, this position is called as an intubating position. Normally you have 3 axes. So one axis is passing through the larynx, another axis is passing through the pharynx, one more axis is passing through the oral axis, through the oral cavity. So if you want to do laryngoscopy and visualize the larynx through your direct laryngoscopy, all 3 axes have to come in line. This is mainly for direct laryngoscopy. So once you keep a pillow, you always keep a pillow about 5 to 10 centimeter pillow under the occiput, elevate the head, flex the neck, so then laryngeal and pharyngeal axis will come in a line. So, but still the oral axis will be almost perpendicular to laryngeal and pharyngeal axis. So this extension of the head at Atlanta occipital joint is very crucial for bringing the oral axis in line with the laryngeal and pharyngeal axis. Then only you will be able to visualize the larynx. So head extension is very important. So now we have found out that many of these tests, and once you have done all these tests, what you can do is, you can go for a simplified airway risk score, and each one, like mouth opening I was telling you, thyrometric distance, neck movement, ability to prognathe, this is upper lip bite test, Mallampati's classification, weight also, obesity also you can look for, and any history of difficult intubation in the past, and all these things you can give points, and if the final points are more than 4 points, then definitely it is better directly you go for a video laryngoscope. Don't try to go for using a direct laryngoscope. If it is more than 7, it is always better to first get the airway by awake intubation, fiber optic intubation, and then anesthetize the patient. Coming to the airway gadgets, now you have few of the airway gadgets I have written here, and anyway tomorrow you have got the airway workshop, you will be able to see many of these airway gadgets. So like face mask, oro and nasopharyngeal airway, supraglottic airway devices, endotracheal tubes, video laryngoscope, bougies, flexible fiber optic endoscopes also. Now coming to the face mask, this face mask is, you all must have already used this face mask. This is called as an anatomical face mask. Why it's called as anatomical face mask? Because it corresponds to the facial anatomy of the adult patient. So that's why it's called as anatomical face mask. It has got a rim, and it has got a body, and it has got an opening for connecting the circuit. And you also have a nipple here just to push air to inflate the cuff, so that the cuff can be very soft on the head of the patient. So how do we hold this mask? So it's called as, you have a EC technique. So here this is an E, wherein the little finger will be at the angle of the mandible. These 2 fingers will be holding the ramus of the mandible. You should not apply pressure over the soft tissue. The ramus of the mandible and pulling the head backwards, and these two, the index finger and then the thumb, will be pushing the mask downwards so that there is absolutely leak-proof space between the mask and then the face. And you can see that easy technique. Suppose if you are not able to hold the mask properly with one hand, you can also use two hands and ask your assistant to ventilate, or you connect the patient to mechanical ventilation and patient can be ventilated. So, but these anatomical face masks not be ideal for pediatric age group. Dr. Asam is going to talk about that differences between adult and pediatric patients, because in the pediatric age group, the facial contours are not very well developed. So you can't use this anatomical face mask, one reason. The second reason is because of the cushion, it produces a increase in the apparatus dead space, and apparatus dead space is very important because then the child will be breathing its own expired gases, can increase the PaCO2. That's why an ideal mask for a pediatric age group is called as Rendell-Baker-Sosek mask. The advantage of Rendell-Baker-Sosek mask is it doesn't have a inflatable cushion, and you can press it over the face of the child, and definitely you can reduce the amount of dead space. So that's why especially you use this. And many times when you are using the mask and trying to ventilate, in an unconscious patient, in a conscious patient, the tongue will be above it will not be occluding the the pharynx and then the airway. But once the patient is anesthetized or unconscious, so the tongue will come down and then obstructs the airway. So in order to prevent that, you are not able to ventilate the patient easily, then you may have to use either oropharyngeal airways or nasopharyngeal airways. So that is what is very important. You always keep this oropharyngeal or nasopharyngeal airways whenever you are managing the patient. And how to know what should be because they come in different sizes. So you just measure the distance from the angle of the mouth to the angle of the mandible. That should be the length of your selecting the oropharyngeal airway. And how do you insert the oropharyngeal airway? Always insert the oropharyngeal airway with the concavity facing the upper incisors, and then afterwards you rotate and then push it deep. So that's how you insert the oropharyngeal airway. So we have these are Giddle's oropharyngeal airway. We have other specially designed airways are also there, like Williams airway, Osapian, Burman, and also Patil Syracuse airway. So these airways, another 5 minutes I'll take. So these specially designed airways are basically for fiber optic bronchoscopies. So now this is the nasopharyngeal airway. So you again know what should be the length of the nasopharyngeal airway by measuring from the nostril to the tragus of the ear. Now you all seen this laryngoscope. So majority of you already must have bought this laryngoscope. This is the Macintosh laryngoscope. There are so many different kinds of laryngoscopes, and most popular is direct laryngoscopes, either Macintosh or Miller's blades. And majority of the times you'll be using the Macintosh blade, and Miller's blades, especially the straight bladed laryngoscope, you may have to use in pediatrics because the epiglottis is large, overhanging, and when you do a laryngoscopy with curved blade, you may not be able to lift the epiglottis. So when you are using a straight blade, you are going to lift the epiglottis along with the tip of the laryngoscope. So another one is called as a Mackay's laryngoscope, in especially overhanging epiglottis or in slightly more anteriorly placed epiglottis. You have a lever is there, you can press the lever, and then the tip will get flexed, and also it can pull up the epiglottis. That is called as the Mackay's laryngoscope. And especially in pregnant women, so because of the enlarged breast, and even in obese patients, the handle the breast may come in inserting the laryngoscope. The handle may have to be shortened. That's why you have a short handled laryngoscopes in pregnant women. And also you can have the obtuse angle laryngoscope is also called as a polio blade. Coming to the endotracheal tube, so you have seen this PVC endotracheal tube, and we have different endotracheal tubes also, because this PVC endotracheal tube for adults has got a cuff, whereas for pediatrics you don't use a cuffed endotracheal tube, you always use an uncuffed. But specially designed endotracheal tubes like this micro cuffed endotracheal tubes are designed for pediatric use. This is armored tube because it's also called as reinforced tube, especially in head and neck surgeries. They are kink resistant. These specially designed tubes are used. They are ring Adair Elvin's tubes. There is a south pole, north pole, and especially cleft lip palate surgeries, head and neck surgeries. These are used. Tomorrow you will have, all these will be shown for you. And this is the Magel's forceps, which is again another important tool you have to use. So these stillets and then the tube exchangers. So you will be seeing all these things, because many times you may not be able to intubate. You can only introduce the tube exchanger or the bougie. Over that you can definitely pass the endotracheal tube. So again another very important thing is there was no bridging between the mask and then the endotracheal tube before. So it was the Archie brain introduced the first supraglottic airway device, that was in 1983. This is considered as a revolutionary introduction. So there are so many supraglottic airway devices are available, insert blindly. So this is a classic LMA and is a unique LMA, reinforced LMA. This is one of the second generation LMA. This is the ProSeal LMA. Because of paucity of time, I will not be describing all these. This is again a ProSeal, and you have LMA Supreme, which is a disposable LMA, almost a sort of disposable ProSeal LMA. The LMA Gastro in endoscopic surgeries, you can definitely use this. And there is an intubating LMA. Everything will be shown for you tomorrow. And another important introduction is by Mohammad Nazir, the iGel. So this is a cuffless supraglottic airway device, so which also has become very, very popular. Coming to the video laryngoscopes, all these time I was talking about direct laryngoscopy. With video laryngoscope, the camera is there at the tip, so that indirectly you are visualizing the image of the larynx, and then easily even Carmack-Lahane grade 4 can become Carmack-Lahane grade 1 with video laryngoscope. So various kinds of video laryngoscopes are there. Channeled video laryngoscopes and unchanneled video laryngoscopes are also available. And the field of vision will be much better with a video laryngoscope. And finally, the fiber optic laryngoscope or fiber optic bronchoscope. And actually this is the gold standard as far as the airway management is concerned. So you always thread the endotracheal tube first, and then pass the fiber optic scope, then visualize the carina. After visualizing the carina, you just push the endotracheal tube through the glottic opening. Just to take home. So properly done airway assessment is very important to anticipate a difficult airway, and you have to do multiple tests. No single test is ideal. When you have a combination of all these tests, like that's why I told you about simplified airway risk scoring you can always do. And you can have a difficult airway card, you can have all these equipment ready, because many times though you have not anticipated difficult airway, you can come across an unanticipated difficult airway. So in order to manage, you should be thorough with all these equipment, and you should be able to use these equipment in such a situation. Thank you very much. Thanks for giving me an extra time.
Thank you, sir. Thank you for the excellent lecture. The only comment I want to make is, when this lecture was over, I felt I had a perfect recap of whatever I was doing for last 20 years. Perfect. But when you, as a starters, you think so many gadgets, so many things have been talked about. What am I going to use? Where you are going to use it? But over a period of your